This is video 5, Medical Therapy for Sleep Apnea. In this video, we will discuss the use of CPAP as well as other non-surgical management options for sleep apnea in adults. Neither this video nor the next applies to treatment of sleep apnea in children. The gold standard medical therapy for sleep apnea in adults, whether this is central, obstructive, or mixed type, is PAP therapy. This is because PAP, or positive airway pressure, has been shown to be more effective than any other medical therapy and most surgical therapies. CPAP, which stands for continuous positive airway pressure, is a portable machine with a face mask. When the machine is used, it prevents collapse of the upper airway by maintaining positive pressure during both inspiration and expiration. BiPAP, which stands for bi-level positive airway pressure, is much like CPAP, except that the positive pressure settings on inspiration and expiration can be independently adjusted. For example, with the common CPAP setting of 10 centimeters of water pressure, 10 centimeters of pressure is applied to the patient both during inspiration and expiration. A BiPAP setting of 18-10 means 18 centimeters of pressure is applied during inspiration, while 10 centimeters is applied during expiration. APAP stands for automatic positive airway pressure. This is a type of CPAP in which the setting varies within a prescribed range. For example, a range of 6 to 12 centimeters of water pressure means the machine would adjust the setting within the range of 6 centimeters and 12 centimeters of pressure, based on how much positive pressure it sensed was needed. This can be helpful in patients who have either increased pressure needs during REM sleep later in the night, or in patients who are diagnosed with a home study and do not wish to undergo a laboratory titration. There are several types of masks that can be used with a PAP machine. The three most common types are nasal pillows, a nasal mask, or a full face mask. Nasal pillows can be helpful in patients with claustrophobia because they have the smallest profile among the masks. They are also the least likely to be knocked out of position in restless sleepers and tend to have the least amount of leak in bearded patients. The drawbacks of nasal pillows are that they can be uncomfortable at high pressures. The associated dryness can cause epistaxis, and they will not work well in patients who are mouth breathers due to nasal obstruction. Nasal masks are very similar to nasal pillows, except that they are larger, so they may not be as good for patients who are claustrophobic. In patients with no nasal obstruction, they can provide less direct airflow even at higher settings, which can be more comfortable. Patients who do not have nasal obstruction but are mouth breathers at night can also use the nasal masks with a chin strap to keep their mouth closed during sleep. The third type of mask is a full face mask. These are best for patients with nasal obstruction who do not wish to wear a chin strap or who require a high pressure setting. The drawback to full face masks is that they have the highest rate of air leak and are difficult for patients who are not back sleepers, since they are likely to move out of position during side sleeping. Obviously, for PAP to work, the patient needs to use it every night. Unfortunately, a significant percentage of patients do not tolerate their PAP machines. In the literature, self-reported use ranges anywhere from 60 to 90%, but we know that objective information from compliance reports shows a lower rate of use. Patients who do not tolerate PAP within their first few weeks of use are the most likely to abandon use over the long term. The most common reasons for intolerance are nasal congestion or obstruction, claustrophobia, and poor mask fit. Poor mask fit can lead to air leak around the mask and skin irritation. Surprisingly, studies have shown that the higher pressure settings are not correlated with lower tolerance. That being said, pressure-related side effects can limit use and include nasal and oral dryness, epistaxis, and eye irritation from leak around the mask. Studies have shown that compliance with PAP therapy can be improved with more patient education about PAP and more contact with their provider. After a patient begins PAP therapy, they need to be monitored. It is useful to know what a compliance report looks like. This report gives information on how many days the machine has been used over a period of time, as well as how many hours per day. It usually includes a graphic of the usage and information on the AHI recorded as well. In this patient's case, he was very compliant, and his AHI reflected this. Once a patient is tolerating PAP therapy, it is recommended that they have a yearly follow-up with the ordering provider. While PAP therapy is the gold standard for medical treatment of sleep apnea, there are several other medical treatment strategies for obstructive apnea. The first of these is weight loss. If a patient is overweight or obese, a reduction in weight can lead to significant improvement and, in some cases, complete elimination of obstructive sleep apnea. The difficulty with this is that there is no established parameters for how much weight loss is necessary to see an improvement. Also, weight loss is not likely to help with any central apneas. Therefore, weight loss is not recommended as a first-line therapy for treatment of sleep apnea. There are 2 other second-line treatment strategies that you should know. First, patients should be counseled to avoid alcohol and other sedating medications, since these are known to exacerbate obstructive sleep apnea by increasing the amount of upper airway collapse. Second, positional therapy can be used. Since most patients have worsened AHI while supine, avoidance of supine sleeping position can improve obstructive apnea. Commercially available sleep positioners can keep a patient from lying supine, as this picture from Amazon.com illustrates. Dental appliance therapy is indicated for patients with mild to moderate sleep apnea as a first-line treatment option. It can also be used in patients with severe apnea to decrease their PAP setting, but should not be used as the only treatment modality in these patients. Dentists can provide these custom-fit appliances, and it is recommended that a sleep study done with the appliance in place be used to confirm benefit prior to long-term use. Finally, keep in mind that there are specific medical and surgical treatments for upper airway obstruction that we, as otolaryngologists, can provide. If allergic rhinitis is affecting CPAP tolerance due to turbinate hypertrophy, incorporation of a nasal steroid spray can improve tolerability. We also perform many of the surgical interventions used to treat obstruction. In the next video, we will address surgical therapies for obstructive sleep apnea.